box, so that's disappeared. Okay. Good. I need to go. What's happened here? I need to go backwards now. It's over here, isn't it? On the left somewhere. Let's see if we're nearly there. Sorry about all this messing around. Okay, welcome everybody. Sorry a little bit late. IT issues with me since I'm getting very old. Welcome to this. Can you just quickly put down in the chat box which part of the world you're from? Which country you're from, very quickly, so I know roughly where you're coming from. UK, okay. Jordan. And okay, so Palestine, okay. Okay. Okay, can we make this chat box a bit bigger, Reynold?
You can stretch it down a little bit at the bottom. If you click on the side of it, you can stretch it down.
How do you mean here? No, here?
Well, no. I can't see from here.
Okay, what are we going to do today? Sorry about the delay. Let's go through a series of cases, a bit like the real world. So you're going to have nothing but a clinic of ENT issues. So here's a 30-year-old man, and I want you to put all your, answers and your comments into the chat box, okay? So when I ask for answers, that's where it should go. So here's a 30-year-old male. He looked in the mirror, and my God, he noticed that his right tonsil over here was bigger than his left. He has no other symptoms. So the first question is, what do you see in the oropharynx? Anything that's the critical thing? I know you can see teeth and tongue, but what's the critical thing you can see? Okay, Amal from it said enlarged right tonsil. Yep, everybody agree with that? Okay, asymmetrical tonsillar. Okay, right tonsil hypertrophy. Yes, very good. Okay. In terms of no other symptoms, what symptoms might you have asked him to decide whether this was serious or not? What other symptoms would you have asked him? Fever, okay, that's Iman. Fever, possibly fever would imply infection. Okay, so it doesn't look infected, does it? Okay, Shiraza, swallowing problems, pain in the throat. Yep. Amal, sleeping difficulties, less of an issue. Weight loss, yep. Shariza, yep. Problems breathing. Night sweats, possibly. But what are you thinking of, Faraz, if you think it's night sweats? What is the worry with a large tonsil? Lymphoma, yep. Okay. The main thing about a unilateral enlarged tonsil is it benign or malignant? And if it's benign, is it of any consequence? Just normal large tonsils that are asymmetrical, okay? Or is it something else, okay? So that's the main thing. Now, the first thing is he had no other symptoms. That immediately makes you think this is probably not a serious problem. It doesn't decrease with antibiotics. Amal, you wouldn't be giving them antibiotics. You don't think it's a fever. Okay. So you don't think this is a serious issue. What is the other thing you may ask the individual in relation to the size of the tonsil? He's had it for several months and he's finally come to see you. What could you ask? Has it grown in size? Yeah, very important. Is this a static issue? Or is it something that has gradually got worse and worse? Anything that seems to get bigger, more uncomfortable is a little bit of a worry, okay? So it's new, Musa, in the sense that he's noticed it, but the important question is, has it got bigger and bigger over the last few months? And the answer here is no. Okay, so you all saw the right tonsil. How would you, on clinical examination, determine it may be benign or malignant? Now, remember, Clinical examination is inspection. You've inspected it and things like that. Remember, inspection, auscultation, palpation, percussion. Okay, Sabira said examine the lymph nodes. We'll come to that in a moment. Okay. Even before you examine the lymph nodes, neck examination, Ahmed, is important. Yeah, okay. Amal has mentioned palpation. So you look at it, inspect it, then you palpate it. So you actually palpate intraorally with your finger both tonsils. So the left one will feel in a particular way. When you feel the right one, it may be bigger, but it doesn't feel hard or irregular. Okay, so in this instance, when you got an asymmetry, palpation is absolutely important. Okay, so that's the first thing. What else might you notice in terms of movement of any part of the intraoral examinations? Are there any other lesions inside the mouth? Dr. Wael, what are you thinking of? Adhered. Okay, so Amal, is it mobile? If it's adherent to the underlying surfaces, you won't be able to move it. So it's immobile, it's hard, irregular, immobile. Okay, that is not a good sign. Anything else? What about if you ask them to say ah? What would you normally expect to see? Ah. Well, we've had the increasing inside, Amal. We don't need to repeat that. I'm asking about clinical examination. Let's just stick with the tonsil. Niraj, consistency, we've said irregular, hard. That's not a good sign. Listen to me carefully. What about if you ask the patient to vocalize ah while you're looking in the mouth? What might make you think this is a serious problem? Okay, Iman has said the uvula. If it's malignant and there is some extension into the palate and the uvula, on that side it will not move so well. So there'll be an asymmetrical movement of the palate and uvula. What about the tongue? If this is a malignant tumor, anything that could happen to the tongue that you can see on physical examination? Okay, so you can feel the base of the tongue, Fares, very good, with your finger, and it may feel different to the other side. So palpation again is important, and the same you could do for the palate. Okay, Amal, move the tongue upward with it. I think you mean there may be restriction of tongue movement. So if my right tonsil is a problem, when I poke the tongue out, my left side moves, but my right doesn't. So it veers. It goes to one side or other instead of coming out. So it does that. Okay. Difficulty in tongue movement. Okay, well, there's an abnormality, Niraj, of tongue movement. And then that's the local examination in the mouth. And early on, somebody mentioned the neck. And you're looking, as we've already said, you're looking for neck nodes. Okay. If it's malignant disease, you're always worried about enlarged lymph nodes. And again, these lymph nodes will slowly be getting larger and larger. What other examination can you do? Because here you can see the oropharynx. And remember, the nasopharynx is behind the nose. We don't know how far this, if it was malignant, is extending in the nose. And we don't know how far it's extending into the hypopharynx, that's lower down, or the laryngopharynx, as it's sometimes called. So it's in the oropharynx. We don't know how much it's gone up and how much it's gone down. What physical or clinical examination can you do to examine the nasopharynx and also the laryngo or hypopharynx? I think Faraz has said FNE, flexible nasendoscopy. Okay, so you can put a flexible scope into the nose. Iman, it's not a not direct laryngoscopy. That's usually done under an anesthetic. In the clinic, you can put a little bit of local anesthetic spray in the nose. Some people don't want even that, or don't even use that. You pass the scope through the nose into the postnasal space, and it can sit above the soft palate. You can examine the soft palate and the nasopharynx. You go lower down, you can see the back of the tonsil pillar. So behind here, you can see, and then you can see actually into the laryngopharynx, the larynx and the hypopharynx, and the entrance to the piriform fossa. So that will be a full examination. And depending on what you find on the clinical examination, married to the history that you've taken and the history the patient has given, you have a good idea whether this is likely to be a benign or malignant issue. So when I ask any other area you would wish to examine, that is what? Now, Amal, I've not asked you any questions. Please only answer questions that I pose. Amal, please. Okay, don't go ahead of yourself. Thank you. So we said, which other areas would you examine? Can you now hazard a guess which areas you would examine? Well, abdomen, well, you might examine the ear. I think the abdomen is probably pushing it a bit, Dr. Mohammed. So Jojo has said the ear. Yeah, I mean, if this lesion is extended into the nasopharynx, it may cause eustachian tube dysfunction and therefore middle ear effusion and hearing loss or even pain. Yep, you definitely need to examine the nose and nasopharynx, dear Raj. That's very good. And what else have we examined? We examined the neck, and one other thing we examined with the flexible scope. Okay, buccal mucosa. It's really the laryngopharynx. So you have direct vision, then you examine the nose, and if you like, the throat and the neck. Okay, that's the laryngopharynx, Dr. Ashwak. The vocal cords you will see when you do the flexible rhinolaryngoscopy. Okay, what do you do if you're worried that this may be a malignancy? If you're in primary care, what would you do? And if you're in secondary care in a hospital, what would you do? Yeah, I mean, you could do an incisional biopsy. If there's an obvious lesion there, you could even do it in outpatients. You just take a punch biopsy forceps. But if this is a general enlargement with the lesion right in the middle, a bit like the core of an apple, if you take the skin of the apple, you're not going to get a proper histological piece. So sometimes the biopsy may be a total tonsillectomy if you were concerned. Okay, you might, if you were going to have a general anesthetic to do a tonsillectomy, you might do a CT scan beforehand. Okay, so if you're concerned, you either can do a biopsy there and then if there's an obvious lesion, but if there isn't, they need to go to secondary care with imaging and possibly a total tonsillectomy. Okay, you don't need to do a total tonsillectomy in all cases because asymmetry probably affects about 80% of the population, Amal. Okay, and 80% of people are not going to require a tonsillectomy. So mostly this is about reassurance. But if you have any suspicion that this is serious, then clearly you may need to take it further. So any questions on this? Are you reasonably happy? Any questions? Okay, so no questions. We'll move on to the next one. Okay. First of all, what's the name of the statue on the left? Who is that? And what was he renowned for? Yeah, Abraham Lincoln, Nicola. And what was he renowned for? Yeah, the bill for emancipation of the slaves. What else did he do? What else did he win? There's a very important thing he won. He wasn't the first president of America. That was George Washington, sir. But he was a Republican, a bit like Mr. Trump. What did he win? He won the Civil War. The southern states of America, or the Confederacy, wanted to keep slavery. The northern states did not, and a civil war ensued, which fortunately Abraham Lincoln won. Do we know how he died? He was shot in a theatre, you know, performing theatre. Yeah, that's right. He was shot and died within a day or two after that. Okay, but he's known. If you ever get a chance, look at the sayings of Abraham Lincoln, a great philosopher, a great individual. Now, he clearly had big ears and with lots of wax. So first question is, what is wax? Have a bash at that. What is wax? What makes up wax? Anybody got any idea what wax? It's okay. Faraz, it's cerumen from the ceruminous glands. Where does keratin? Well, it's not keratin. Keratin is really nails, isn't it? Dead skin. It's dead skin. Squamous epithelium, which is desquamating. Anything else? Cerumen, dead skin, and sweat. Okay, so it's a mixture of that, and the quantities of each will determine the color, the smell, and the consistency of wax. And therefore, those that have looked at many years will see a whole variety of colors, consistencies, and smells. Okay, and how often is wax produced in the ears? Secrets. Daily, frequently. Anybody, any other takers? I think Faraz and Niraj are doing lots of answering. How many people we got? We got a lot of people on here. We want some of the others to have a go. Right. Yeah, that's just cerumen, but wax is not the same as cerumen. People don't understand that. Said, you're correct, but wax is more than just cerumen. It clearly contains cerumen. Okay, what was my question? How often do you produce wax? It's like present-day supermarkets. How often are they open? Well, they're open daily. What do you mean daily? 9 to 5, and then the ear stops producing wax, Iman? Ahmed? Does the wax? Sarah? Does the ear work for wax, producing wax between 8 and 4 every day? 24/7, yes. Wax is produced all the time, and the quantity in individuals is a continuous process. Yes, Sarah, absolutely. So you and me have produced a truckload of wax since birth, and it's all come out. Okay, so there's a natural extrusion mechanism. Okay, so you can't stop wax from forming. Good ears produce wax. Not good ears don't produce wax. So does wax have a purpose? Tell me what purpose. Does it have a purpose? Or is this a design fault by God? Okay, Mamoon, you say protection. What from? COVID-19? Barrier for insects and foreign bodies? No. Protects the ear from dust, foreign particles, water, irritant? No. It removes foreign body? No. Dust? No. You need hairy ears for dust. Okay. Best not to have a canal. Bread for no. Lubricant? No. Why do you want to lubricate your ear, Iman? Moisturization of ear? No. Cleanse the ear? No. Shielding the eardrum? No. It doesn't lie on the eardrum, does it? Here's the eardrum. Here's your ear canal up to here. Wax is not produced in the deep part of the ear canal. It's produced in the lateral 2/3. Ah, here we are. Who's that? Shalina. Very good. You say antibacterial, but it's antimicrobial. So it has lysosomes and God knows what else in it, which, because it's a cul-de-sac, your ear canal is a cul-de-sac. Okay, in you go. There's a tympanic membrane, so it's a cul-de-sac, and it's nice and warm. A great environment for microorganisms to multiply. So it has an antimicrobial property. So it does have a purpose. Okay, I've told you that wax clears naturally. You and I have produced bucket loads of this stuff. So what do you tell parents who come to you with their children and say, he's producing a lot of wax, I have to clean his ears here every single day? What do you tell them? What, you just say it's normal? That's fair enough. You can leave it and don't be anything. Yeah, stop cleaning. Yep. Sort of there. Anybody else? Reassurance, very good. Extra, they don't have to clean it in turn. That's right. All right. Yep. Okay, what I say, wonderful, fantastic. The ear is working properly. He's producing wax all the time, and God has designed the wax to extrude naturally. And where's it going to go? It's not going to go into the head, into his brain. It comes out of the ear canal. So it means his ear is functioning wonderfully well. Okay, and you don't have to encourage it. Don't put anything in the ear. You just can clean just the outside. What this bit, which is called the concha, which is like a boat, you can clean that bit, but put nothing in the ear. So what should you put in your ear? The only thing that you should put in your ear. If patients say no, you don't need olive oil. I mean, 8 billion people don't need olive oil. Nothing. So you should not put anything in your ear. However, what I normally tell patients, so they remember to put nothing in their ear, is to say the only thing that should go in your ear is your elbow. Your elbow can go in your ear. So they try. Some people even try. That's the only thing that should go in your ear is your elbow. Okay. Right. Any questions on this particular case? So this particular picture is doing the wrong thing, cleaning Abraham Lincoln's ears, but it is a statue, so I suppose he's forgiven. Any questions? On wax? Okay. Let's see what happens next. If tinnitus. Impacted wax, the most appropriate treatment. Tell me, Amal, how are you going to get rid of impacted wax? Impacted means absolutely solid. Okay. Now, let me, yeah, it may be suction. Okay. But it can be very hard and it can be quite painful. Suction is possible. Yeah, hearing, yeah. Now, the thing about impacted wax is that if you give wax softeners or ceremolytic agents, the wax absorbs the water, the solution, and it expands. And that expansion can cause increased pain. So softening and ceremolytic agents are usually good if the canal is only half blocked. If it's fully blocked, the patient may complain that you've made them worse. So always warn people who've got completely blocked ear canals that if you give them softeners, it might cause additional pain, in which case they need to come back to you earlier and you can suction it. Maybe you can suction it there and then. That's the kindest way to do it. Some people use syringing. The thing about syringing is that if you've got a blob of wax here, you have to get the water jet to go behind the wax so it pushes the wax out. So you have to direct it posteriorly and superiorly, and then the wax comes out. If you don't get the wax out, the water will get absorbed and expand the blob of wax and make the patient worse. So I frequently see patients who've had attempted syringing and they haven't managed to get the wax out, and the patient feels it's more painful. Okay. So there's a number of ways that one can approach hard wax, impacted wax. Generally speaking, if you can give them a softening agent and then try and syringe or preferably suction it. So most suction will be done by an ENT specialist, although in the UK we do have nurses that do this. Any other questions just on wax? Anything burning issue that somebody wants to bring up? What do you mean, Dr. Ahmed? What do you mean? It doesn't affect the pressure in the ear. The patient complains of pressure. So hearing loss can be described in various ways. It feels like cotton wool. I can't hear. There's an odd pressure. I feel peculiar. Okay. The description is multitude. You can use hydrogen peroxide, but the best agent, one of my colleagues did some studies on this, seems to be sodium bicarbonate eardrops are probably the best. Okay, sodium bicarbonate eardrops. And okay, let's move on to the next slide. Okay, here we are. Okay, now there are a series of audiograms and tympanograms. So there's some audiograms and there's some tympanograms. Tympanograms basically tell you how easy it is the eardrum is moving. Okay, and the audiogram tells you how well you're hearing pure tones. There's very little in life that's a pure tone because sounds are usually mixed and multi-tone, but that's the way audiograms are done. Okay, so what we want to do is I want you to select the correct image. So let's go in it one at a time. Select the correct image, A, B, C, or D, or E. Okay. And for C, select the type of curve. So the first thing is, what is normal? A normal audiogram. Okay, everybody got that. Normal audiogram. Left ear is X's, sinister, X, and circles are right here. Anything that's 15 to 20 decibels or above is considered normal. Okay, so that's good. Now B is glue ear. Okay, that's fluid in the middle ear. Okay. and some hearing loss. Sorry about that. So somebody's written E. That's Iman, Damilola. Okay, so an otitis media with a fusion or glue ear is going to produce a conductive hearing loss. Okay, so that the sound when it hits the eardrum is supposed to go through an air cavity with the 3 bones, and those 3 bones can move very easily through air, but at the moment you put water in it, it's so much more difficult. So when you swim in fresh air, it's easy. They're the bones. When you go into the water, it's just so much more difficult. So you need more intensity. So E shows a conductive hearing loss. So that's the bone conduction. That's stimulating the cochlea directly, and it's normal. But if you stimulate the cochlea through the normal channel, external ear, middle ear, where there's a problem, inner ear, cochlea, then you need more intensity. You need about 40, 45, 50 decibels intensity to hear 250 hertz, 500 hertz, 1 kilohertz, to, you know, the various frequencies. And so there's this air bone gap. That's the bone and that's the air. It's called an air bone gap. And the tympanogram, that means how well is the ear moving, is reflected in which of these tympanograms? Type A, type B, type C, type AS, type AD. Anybody? Type B. Anybody else going for type B? Anybody else? Because if you can't do an audiogram and you think there's a glue ear, the simplest thing is to do a tympanogram, because you can buy special machines. You just stick them in the ear and they do a tympanogram reading for you. And then it confirms your suspicion, clinical history, physical examination, and a quick investigation. Anybody else? What type of tympanogram? C. Okay. Iman. Anybody else hazard a guess? C. Okay. Hamad is also type C. Anybody else? Okay. Well, I think you're both right. With a really full-blown otitis media with effusion, or glue ear as it's called, it doesn't, what you do is you change the pressure in the ear canal. You produce a negative pressure, so the eardrum gets pulled out. And if you raise the pressure in the ear canal with this investigation, the eardrums gets fully pushed in. Now, when the pressure is the same here and on the inside, the eardrum moves nicely. I mean, a curtain will, a sheet will only move nicely if the pressure on both sides is the same. If you put a lot of pressure here, it's going to tend to go that way and not come this way. So it's rigid. So it doesn't matter what you do to the pressure here. If you take it from 0 to 200 centimeters of water and also a negative pressure, the eardrum hardly moves. So that would be a flat curve type B. That is very common. Sometimes there's a little movement. The pressure in the middle ear is relatively negative, so it's almost flat, but not quite flat. And the middle ear pressure, where the peak is, that peak tells you what the middle ear pressure is very negative. So here it's about -250. Whereas in a normal tympanogram, when you raise the pressure, the eardrum gets stiff. When you decrease the pressure, the eardrum gets stiff the other way. And where it moves maximally is the middle ear pressure. Here it's 0. but generally it's about -50 or so. You generally have a little bit of a negative pressure in the middle ear, but here is very negative, and negative pressures produce glue ear and otitis media with effusion. Is that sort of clear? Is that reasonable? So you get a flat curve, a type B curve. So if somebody asks you for an instrument to measure the ear, an audiogram is quite time consuming and it needs a soundproof booth, but many things you can investigate with a tympanometer, which will give you these curves: a normal curve, a glue ear curve, a sort of a glue ear curve, but also eustachian tube dysfunction. Okay, any questions? Okay, pneumatic, yeah, you can do pneumatic otoscopy. It just tells you whether the ear is mobile or not. Okay, but frequently, if you've got an intact tympanic membrane, you can just get them to do a Valsalva, and if the eustachian tube is functioning, you'll see the eardrum pop out slightly. Okay, but with pneumatic otoscopy, provided you get a seal with the speculum and you pump the bladder and the eardrum stays stiff, it might mean that you have glue ear or otitis media with effusion. Any other questions? Okay, let's move on to presbycusis. Presbycusis. Which curve is that? Okay, A, Nicola, A, that's an easy one, isn't it? Okay, so with presbycusis, what's the key features that tells you this is presbycusis? I mean, assume the patient's 70 years old. What are the key features that tell you this is presbycusis and unlikely to be bilateral acoustic neuroma? Oh, so it's symmetrical, high tone. Okay, so symmetrical, both ears are the same. Left ear, the X's, right ear, the circles. It's the same. They're bedfellows, one on top of the other. Okay, it's symmetrical. It's the same in both ears. And it's mainly the high tones. Usually round about the 2000 hertz, it heals off. Okay. And this is classical. Okay? Symmetrical high tone hearing loss. So how do these patients present? Anybody hazard a guess? Partner present. What, you mean the partner says, my husband doesn't listen to me? Well, they might present with a hearing loss, or those around them say they don't hear very well. Problems hearing speech, especially crowded places, background noise. Yeah, absolutely. And the reason for not hearing well in background sounds is that background sounds mask high frequency sounds particularly. And the most important sounds in language are consonants, not the vowels. So if you take a sentence and get rid of all the vowels and then try and pronounce what's left, you can make some sense of it. Okay, so here, if we look at this sentence here, let's look at this sentence here. If I don't pronounce the vowels, that's only the consonants, this is what you'll hear. You will hear gl, ria, tit, tit, medi, with a few z, sil, tek. Okay, now if I take out the consonants, you will hear this same sentence as u, e, id, i, u, I. Complete nonsense, isn't it? So high frequencies are the consonants which give words structure and more easily comprehensible. Okay, that's why they can't hear. Everything sounds jumbled up. Everything sounds jumbled up. Okay, and they do have this problem with background noise because it makes consonants even harder. Okay, let me just take that. Hello. Okay, let's go to D. Audiogram seen in wax impaction, which we've spoken about, and a perforated eardrum. What sort of audiogram are you going to get there? D. Niraj said D. Anybody agree or disagree with Niraj? I've got my pet dog here scratching away. Any others? Anybody else, please? Impaction, wax impaction, and a perforated eardrum. Hello? Hello? Can I ring you in about half an hour, please? Give the lecture. Thank you. Anybody else? Only Niraj is going to hazard a guess. D. Anybody else? Can you all hear me? D. Okay. Samar said D as well. Anybody disagree with them? I think E. Okay, that's Hamad. Farah says D. Okay, well, I'm afraid Hamad is the correct one. Wax impaction and a perforated eardrum is going to give you a conductive hearing loss with an air bone gap. That is what you have here. I agree D also has an air bone gap, but at 2000 hertz here, there's no gap. There's a notch, what we call a notch. This one has no notch. Okay, so in wax impaction and perforated eardrum, you tend to get a consistent conductive hearing loss across all the frequencies. So you're more likely to see the audiogram E, okay, because there's a conductive hearing loss across all frequencies. And what about otosclerosis? Select both an audiogram, that's E, A, B, D, or E, and an image from C. Audio is D, Iman. What about AS? Somebody said AS, Faraz, Tympano's AS. Yeah, so in this instance, in otosclerosis, you generally have a normal looking eardrum. Anything that's a normal eardrum, let me just, sorry, just give me a second. All right, sorry about that. Are you all there still? Good, I hope you're all there. Okay, so it's otosclerosis. You get a fixation of these stapes, or stirrup as it's called, in the oval window. And it's like a conductive hearing loss. So you can see the conductive hearing loss here, but for some reason, the bone conduction at 2000 Hertz, as indicated here, is excessively affected. It's called Carhart's notch. So this is a classical picture, a normal eardrum with a Carhart's notch, conductive hearing loss, and you get a type AS tympanogram because the middle ear pressure is normal. Okay, so 0 here, 0 here is a normal drum there. And the reason it's actually lower is because the whole thing is a little bit stiff. The middle ear is a little bit stiff because of the stiffness of the stirrup. So it's like a compressed type A. Okay. Any questions? We'll do about another 5-10 minutes. Any questions on that? You're all happy? Yeah, only the stapes is affected. Yeah. Yeah. So the sclerotic plaques around the stapes. Okay. Anything else? There is a condition which is called cochlear otosclerosis, but it must be rare as rocking horse manure. Okay, that's the inner ear being affected. Now, I wouldn't worry about that for the purposes of your teaching. Okay, let's move on to the next question then. Okay, very quick one. Patient 6 days after a tonsillectomy. Why may they seek a consultation? List 3 to 4 reasons. This is 6 days after a tonsillectomy. They may because of pain or bleeding. Yep. Because they think it's infection. Yep. Pain, bleeding, infection. Anything else? Not breathlessness, not really an issue usually. Possibly a fever, but usually not a fever. Yep. Sabber, difficulty eating. They can't, eating is difficult. Not secretions, it's usually not worried about. They're worried about it looks infected. What's the other big one? What's the other symptom that patients... Dysphagia is the same as difficulty in eating. Vomiting, well, that's going a bit far, isn't it? You don't usually get vomiting at 6 days after tonsillectomy, but it's the appearance. And so, halitosis, possibly, yeah, that might be. That's not one I thought of, but it's certainly a possibility, Shalina. What's the other symptom? Do you know which nerve supply sensation to the tonsil and tonsil bed? No, most common is not bleeding. That's fairly rare. It's less than 1% of the population who've had tonsillectomy. Ear pain, Sarah, yeah. So you get referred pain through the glossopharyngeal nerve and sometimes the vagus nerve, both of which also supply sensation to the ear. So the throat discomfort and pain may be minimal compared to the earache, and they come back to you with earache. Okay? It's rarely that it's infected. It just looks like that. There's a temporary slough or secretion that covers the raw surface temporarily, and that will re-epithelialize over 10, 14, 21 days. So things will get better. But sometimes it's worth, particularly if you think there's a little bit of blood, it's probably worth putting them on antibiotics. That's called a secondary hemorrhage. Okay? A secondary hemorrhage. You have to be wary of a secondary hemorrhage because you may get a little bit of coughing up blood and then an almighty cough. So always take bleeding seriously. although it's quite uncommon, less than 1% in studies done here in the UK. Okay, so dysphagia, you give them pain relief. Halitosis, get them to eat little bits often so it washes away that slough that can be a bit smelly. Okay, and the earache will go as the lining regenerates, and tell them that this is the way it looks and it's not infected. But if it's a lot of pain, painkillers and perhaps antibiotics. Okay, bad odor is halitosis, Hamad. Okay, any questions on that? No? Okay, let's do the next one then. Here we are. Okay, match the history with the ear image. Let's go to number 1 first. This is an extremely itchy ear, mild discomfort, and some discharge. There may be more than one image. B. Anybody else? Okay, most of you put D. What's 1 and 2? D1 and D2? No, okay. B. Somebody has put B. Who's that? Dr. Niraj. Okay, right. What's the first 3 letters of the question? Extremely itchy ear, mild discomfort, and some discharge. Now, I can understand why a lot of you have put B, but this is more likely to be A. A is a fungal otitis externa, which produces usually a very, very itchy ear, not terribly uncomfortable, and only a little bit of discharge. Okay, that's a fungal otitis externa. Okay, and you can see the Aspergillus spores. You see this black, there's a few black spores there, not that many. So this is likely to be an Aspergillus niger, but the common one is Candida albicans. So I think number 1 is probably A. That's what I would go for first, but I can understand why a lot of you put B. What's the secret of fungal otitis externa? How do you treat it? How do you treat it? Yeah, you need to clean the ear out, suction, oral toilet, maybe once or even twice a week. And it's the hyphae. These are the hyphae of the fungus that you need to clean. And the spores germinate over a period of time. So even if the ear looks completely clean, you need to keep using topical antifungal drops. Clotrimazole, for example, or Canestin, one of those antifungal drops. And you need to continue using them for at least a week or 10 days after the ear looks completely clear, because if there are residual spores, the ear looks clear, but they'll come back a week later, 10 days later, saying it's the whole thing's come back, because you can't kill spores. The coat doesn't enable the antifungal agent to penetrate, and so you have to wait till it germinates before you can kill it. Okay, now number 2, the question is, this person has had some long-term hearing loss, non-progressive, occasional discharge, recently hearing worse, and the ear discharging more so with mild pain. What is that likely to be? Which image is that going to be? well, it could be two images, D1, D2. A lot of people have put D1. Yeah, it's D1 and D2. So chronic discharge with some hearing loss, not a great deal of pain, is usually a chronic suppurative otitis media of the tubotympanic type, the not so serious one. If you get a little bit of discharge and progressive hearing loss, then you've got to worry about cholesteatoma. So you need to look at this ear. The chances are there is a perforation similar to this, a central perforation. It doesn't affect the margins here. A marginal perforation would be a dangerous perforation potentially. And the middle ear occasionally gets infected, or the middle ear, which has mucus glands producing mucus all the time, the discharge comes out, this mucoid discharge. It's a bit like snot that you get from your nose, exactly the same, but it's coming out of your ear, here and here. So this story with long-term hearing loss, not really very progressive, occasional discharge, the hearing's got worse because it's got slightly infected. That is classical of chronic suppurative otitis media of the safe type. Okay, number 3 is recently increasing and now severe ear pain, worse on chewing, and significant hearing loss with some discharge. Put B. So what's the diagnosis? Everybody's going to put B, aren't they? Well done. So what's the diagnosis in B? What do you think the underlying diagnosis is? What's the underlying diagnosis? It's an otitis externa, Hamad, absolutely right. No, malignant otitis externa is rare as rocking horse manure, Shalina. It's not otitis media, Iman. It can't be otitis media. Otitis externa, Ahmed, yeah, that's fine. External otitis. Malignant otitis externa gives you this pain and some discharge, Shalini, but it's usually in immunocompromised patients or diabetics or the very elderly. They get minimal discharge. The pain is excruciating, and they usually have cranial nerve involvement. Okay, and it's very common. I've only seen maybe 3 conditions in my whole ENT career of 30, 40 years. So you're unlikely to see it in medical practice. Why is there pain which is worse on chewing? They say when I eat, it's painful. Why do you think that is? Right. Well, it doesn't tell us why, Iman. Chewing moves the external ear canal. That's Faraz. No, it's not nerve involvement, Niraj. The ear canal is here, and the jaw joint is here. So when you eat, you move the inflamed ear canal, and that is very painful. So if you stick your little fingers into your ears, do that now, right as deep as you can without hurting yourself. And just move and just open and close your mouth and see if you can feel the movement on the tip of, in the pulp of your little fingers. Can you do that? Did it move? Okay, so the ear canal gets, cartilage gets moved when you move your jaw joint. That's why it's painful. And also with otitis externa, if you move the pinna, that also stimulates the external ear canal, the cartilaginous part of which makes the ear canal, and then you have the pinna. So when you move the pinna, you're moving the ear canal that's inflamed. And so even a little bit of pressure over the tragus, that little squiggly bit anteriorly, that's usually excruciatingly painful. And that tells you it's an external otitis, not a middle ear infection. Okay, you get some discharge, but not a lot because it can't come out. The external meatus is so swollen, you get hardly any discharge. Okay, how are you going to treat this in the last 2 minutes? Anybody hazard a guess how you might treat this otitis externa? No, it depends on cause. That's not an answer, is it? Look at this ear. How are you going to treat it? I'm not sure what you mean by cause. Okay, are you going to be able to get antibiotic drops into this? Are you going to get Otomize into this? You're not going to be able to get Otomize or antibiotic drops into this. So how are you going to treat it? You could try an Otowick. That's certainly what you should try. It's like a little tampon for the ear. Okay, Shalini, I think that's not at the moment. You put this wick into the ear, can be a bit uncomfortable, but there's usually a tiny little gap to put it in, and then you give topical drops. Okay, frankly, you can give any topical drops, so Sofradex, Sofradex, gentamicin hydrochloride, anything with an antibiotic and a steroid agent. What else might you give? So topical antibiotics through an Otowick, and you generally, I would give them, if it's this bad, I would give them oral antibiotics as well. Okay, and they use the drops in the ears 3-4 times a day. And as the ear canal widens, the wick might just drop out. They don't need to put it back. It means the edema has settled, and then they can apply drops directly to the ear canal. Okay, and you give them the oral antibiotics. And most importantly, what is the other thing you need to give them? What else do you give them? Pain relief. And what instructions do you give for the pain relief, Damilola? What instructions? Okay, we don't have to be too specific about NSAIDs and all the rest of it. What's the most important? Whatever pain relief you give, what is it? Take after food? Well, what's the most important thing? Okay, that's just the pure instructions. What else? No, I'm not asking you the type of analgesia. That's for you to decide. But what is something else about the regime of the painkiller in patients with severe otitis? What do you tell them? Anybody? You tell them to take it regularly, whether they have bad pain or not. Because what patients tend to do is they take the painkiller and then they wait for it to be excruciatingly painful, and then they try and take it again. And you know how difficult it is to get on top of pain when it's excruciating. You'll need, opiates or something like that. But if you get on top of the pain with a good dose and then just take regular painkillers, you don't get breakthrough pain. Patients frequently say, those painkillers you gave me, doc, are useless. Well, they didn't take them on a regular basis. Okay, so at least 2, 3, 4 days, regular basis. Okay, and then they can tail it off as the situation improves. Okay, I think we'll call it a day. There are some other slides, but we'll meet again, I'm sure, at some stage. Any burning questions more generally, and otherwise we'll sign off. Any comments? Thank you very much, Faraz. You'll get a survey monkey, so please complete it. It's useful for the university, and also I need it for my general medical counsel. Tell them something of what I teach is useful to our junior and upcoming great doctors. You didn't understand what about the oral antibiotics, somebody said? Oh, I didn't understand why oral antibiotics in otitis externa, Amel. Well, if you get very severe otitis externa, the risk is that it goes into the cartilage, producing a perichondritis. So if it's really bad, what you're really trying to do is prophylactically prevent perichondritis. It's rare to get it, but once you get it, it's very, very difficult to control because the perichondrium doesn't have a blood supply. So it's very, very difficult. And the moment you get a perichondritis, the cartilage, which gives you the structure of your beautiful ear, particularly ladies, that's lost and they end up with cauliflower and distorted ears. You don't want to do that to any human being, let alone young ladies. Okay, so oral antibiotics, not in every case, because sometimes you see an early otitis externa, it's not that bad. The pain's not too bad when you manipulate the pinna. It's not terribly painful when you eat, and the ear canal is open. You can get antibiotics in there, so you may not give it. So bad cases like the one I've shown you here, yes. Is that okay? How can you do? The only way you can really differentiate is with a culture and sensitivity, taking the swab. However, fungal otitis externa looks like this. The sort of a blotting paper. Remember the old blotting paper, wet blotting paper? It's not the classical discharge like this or mucopurulent discharge. It's wet and gooey. Okay, it's the appearance, and sometimes, as I said, in Aspergillus niger, you see these little black spots, which indicates it's a fungal infection. Okay, when you see a fungal infection, it's usually pretty obvious. It's like wet white blotting paper appearance. Perichondritis, well, it's very severe pain and it doesn't get better. Okay, despite your WIC and your oral antibiotics, and then you're going to have to go into long-term antibiotics. You may even have to do an operation to take away the avascular cartilage that's appeared. So it's a nightmare. By that time, you should have sent it to ENT to look after. You can't look after it in primary care. Any other questions of any note? Most are going to be antibacterial, bacterial infections. Okay. Enjoy yourselves. Thank you very much.